show you the business intelligence tool we used in Mayte to do a bit more analysis about triage. I've been healthcare homes practice for the last 4 years, and probably the thing that troubled us most really was acute demand when we got going. Some of what I'm going to describe may actually not be relevant for other parts of the country, because some places have got better doctor supply than we have in Northland. Also, the tools I'm going to describe may not be the ones you use. But I think the philosophy behind this and the process behind it is something that we can all learn from. We're continuing at my own practice to fine tune this, and by no means are we anywhere near getting this 100% right. So I'm just going to just share the screen with you, and I'm just going to show you a little. Oops, I've got to consent to listening to myself. My God. Here we go. So the little picture here about the train wreck is really a little joke we used to have at our practice. Standing on the back doorstep after me and my partners would brace ourselves for walking through the door, which was really often into a wall of people coming up to ask us questions, people being tried to fit in as extras for the day. It was just inundated. We weren't really keeping up with acute demand. We saw that starting the triage as part of healthcare homes is one of the big drivers. We actually took up the healthcare homes model. So aimed really, I guess, philosophically, not only with triage, but also with our patient portal work. So we've got about 65% of our adult patients on a portal now, but it's wherever possible to value their time and actually do as much as you can without them having to leave the house. So both those things, portal use and triage, is something that would do that. I think too, we often talk about patient experience with this. So, you know, offering a service like this is really good for patients. There's no doubt about that. But also for us as our team, the difference it's made to our ability to deal with the daily load of work has been quite profound. And we can't really imagine ever going back to it. I don't know of any practice in New Zealand who are doing triage who has thought that it was a bad idea and has actually gone back to what they were doing. I've seen a lot of pushback from medical colleagues who, because it's new work, are a little bit unsure about how this will play out. And interestingly enough, some of those that were most opposed have been sort of the biggest benefiters of it, and that said that it's changed their way of dealing with their day, and I've been very pleased to carry it on. This is slightly a busy slide, but about a year or two into our launching healthcare homes up in Northland, we did a qualitative survey around what people thought about the various components of the initial establishment of healthcare homes. So the green box in the middle is how pleased various members of staff were across Northland with components of the model of care. Probably very noticeably, look how green patient triage is among admin or reception staff. For them, as part of your team, this has probably been one of the nicest things we've done for them. It's taken them out of the requirement to make clinical decisions about acuity or how urgent things are when people ring up. They like the lean process. They like the fact that it runs all day in our practice and they don't have to make decisions that were previously really difficult in fully booked days across the practice. Likewise, probably half the satisfaction for doctors was actually doing triage, which surprised us because initially it was quite new and required a fair bit of fine tuning, but they all now like it. Managers like it and the nurses like it. The nurses do it all day at our practice after the doctors finish. For them, they often scratch their heads a little bit actually about our doctorly conversations about triage being something new and different and challenging, because our nurses have done it for their entire career. They ring patients, receive phone calls from patients, triage patients almost continuously. It's part of what their career involves. So they have not seen this as anything challenging or particularly new for them. They like the standardization of the process and the form we use, and other than not being able to prescribe, they are able to resolve it at a very high rate. I think too, for you guys outside of Northern, I often show this because one of the reasons we actually do like people to stay at home is Northland is incredibly big. So from Cape Reinga to Mangawhai is the same distance as it is from Auckland to Turangi, distance-wise. That's a state highway 1. Our state highways in Northland have got potholes. 2/3 of our population live on metal roads. From Makere over to Russell is the same distance as from Tauranga to Hamilton. So it's a spread out thing, and if you can keep people from having to come in because you can organise whatever they need on the day at home, it's an enormous bonus for them from a patient's point of view. The other thing too is that we often get a pushback about why would you want to triage people away? Why don't you want them to come in? Why would we be turning away co-payments? And what we do know is that the mass of not having to overutilise or see people that don't need to be seen is actually good for business. So I'm not quite sure why I wasn't showing this when I started in general practice, or why this isn't commonly known, but quite often practice managers might get it, but my colleagues, general practitioners, often don't quite understand this. So this is just a quick thing, that if you had someone didn't come in and visit you at all, zero cost to your practice, then they're going to bank the capitation for the year, and that's your profit margin. Costs about $75 to see a patient at the practice, and obviously going to pay you a co-payment. For VLCA, the co-payment is quite small, so for them, this following graph is a little tighter than it is in my practice. But after one visit, you're going to have to spend about $75. I'll give you some money. If you follow that up, there's actually a tipping point where you actually are paying more to see the patient than you're getting revenue across the course of the year. So either you have to reduce your face-to-face consults, or you reduce the cost per consult. And we've got fixed fees, so reducing utilisation rates actually is quite useful for your profit margin. We've done the maths. So at my practice, it's 3.4. So once on average, a patient's seeing more than 3.4 times a year, we are losing money. Our elderly patients, particularly high utilisers with a not fit for purpose capitation formula, and an ageing northern population, are actually quite expensive. We're not funded to look after people in a sensible manner by any means. But that's useful to know. The reason you might want to turn people away is not only because it's clinically appropriate, it's good for them, but it's actually quite good for business. So just talking about phone assessment and triage itself. The domain inside our Healthcare Homes Collaborative was either at number 1, patient needs to be assessed by triage and you're not doing it, right through to it's done systematically throughout the day using a clinician who can diagnose, order investigations, prescribe at times of heaviest demand. Triage systems support continuity of care where possible. So that's sort of gold standard. You could probably add more to that, actually. You could probably, add in terms of how we're doing it, that supply and demand is matched according to needs so that people aren't waiting. We're aiming to get to that right-hand side. Even if you're at that right-hand side, number 4, there's still lots of ways of fine-tuning the process. The other side of this is stealing Helen Parker's lovely patient test, is that not doing this actually is quite hard to explain to your patients. So if you said to them, currently, I've got a way that you could ring up in the morning, talk to you for a few minutes, find out if you needed to come in, we could sort it out over the phone, I will, but I'm not going to do that. I'm going to make you drive in and see me, even if it's something that would take 3 minutes. That's pretty hard to defend. I think you'll find that once people realise that a service is available, it's good for both the provider and good for the person. It would be hard to say that you're not offering that service. That, again, is another way of visualising that. That little blue dot there is a practice in the middle of Whangarei, and all those red dots are, in the course of a quarter, I think it was, places that practice has managed to resolve through triage that patient's problems. Some of those drives, I mean, you got right bottom left out of screen almost, is over in Dargaville, but most of those rural ones are going to be a good hour and 15, hour and 20 minutes drive to the practice. They didn't have to leave. That, even though in a big city, even like a major city, somewhere like Auckland, even if you're quite close to the practice, it might take you 45 minutes to get there. And if you don't need to go, you don't need to go. So that's fairly persuasive in terms of understanding what it looks like if you're providing a service that works well for patients. This is slightly busy. This is the view of the healthcare homes model with the patient or whānau in the middle. And the only bit we're doing there is 7.4, which is down the bottom left there, which is assessment and triage. The model for our practices looks even busy. You think, how am I going to do all these things that I'm meant to do? That's a lot of work. But if you just do telephone assessment and triage, simultaneously when you do that, you cover a lot of your urgent and unplanned care. You improve patient wait times, you give same-day access to appropriate services, and you access care during business hours. Outside of that, though, from actually your routine and preventative care, even inviting acute care does a whole bunch of things, and it does with business efficiency. I could show the same sort of model with a patient portal. Quite often embedding triage and portals does a whole lot of stuff to your practice that make it run more smoothly, almost in one go. So despite the fact the model often looks quite daunting, there's some things you lay down and put in place make an enormous difference to your workflow, your staff satisfaction, and your own satisfaction. So we do this because it does value patients' time. We do it because it gives other access options other than face-to-face consultations. It's good for business, improves the capacity, frees up time for proactive and planned care, which is somewhat difficult if you're in places like Northern, where it's actually really hard to find doctors. I think what we've managed to do is we managed to get our head back above water. Some of the proactive and planned care is still work in progress, and I think it probably will improve as we improve business practices, but it's still hard when you haven't got enough full-time equivalents. Gives patients a choice too. Our patients have now had this service running for 4 years, so they're all of them would have probably used it more than once, and are used to ringing up and going, can someone give me a triage call this morning, and knowing that how the process works, and that they might well find that they can get things sorted quickly for themselves. Then the other thing we've done is that we've really standardized the call handling for people requesting same-day appointments. That not just the call handlers who ring in the call, but also us as providers and how we speak to patients when we first talk to them after they've been put on our triage list. So for the call handlers, it's such a joy to be able to say, first of all, we do have appointments today. Suddenly the load is off them and the patient to be ringing up, feeling crook or wanting something done, and wondering whether they can get through the door. It standardized the approach. It actually would imagine improve equity, because in fact everybody, regardless of who they are, will receive exactly the same reply to their phone call, and they just say, we'll get one of our clinical staff to give you a call back. Can you please give me the best phone number? Hold on to your phone. It's probably going to be about 5 or 10 minutes or whatever. They can often see how many are loaded up, and could you give us a heads up about what's going on if you like. Most people will tell our call handlers what they're ringing about. They might say they got a cough or a UTI or an injury. So we've got a little idea. I'll show you when I get into the practice, but they end up in a triage book. I do the same. I say, hi, it's Andrew here, ringing from Bush Road. We've got an appointment today if we need it. Give me an idea what's going on. We'll work out a plan of action. So again, the patient knows that I'm not trying to keep them away. I'm just trying to work out what's best for them. It makes it really easy, and patients have got used to that process, and we've got used to being able to repeat that over and over in terms of standardizing our approach, which means that patients don't get confused. We provide that service all day where we're open. That also makes it a lot easier for both our call handlers and ourselves to understand that this doesn't stop at 10 o'clock in the morning, and then people may or may not get put in after that time. And I think if your practice is even small, you could do this in blocks. You could come back to it at certain times of the day. But to run it all day is actually standardizing it for the patient, standardizing it yourself, and make sure daily load work better. So we're also, I'm going to show you some stuff about matching call volume without the outcome data. So we've actually got a better match between supply and demand for our appointments for the day and our call handlers. So that's what I'm saying. It's about I'll take you another screen. So taking the daily temperature of the day of the week, management of your daily book on the days to make sure you get supply and demand right, and almost trying to work out what the best mix of doctors versus nurses time are. So I'll just go stop that share. Obviously, not what I wanted to do. Two places we'll go to. So I just going to show you here. I don't know what you guys are doing actually with, this is inside my live medtech. It's not a real patient, Sarah Kiwi from La La Land, but we have installed Ken Leitch's clinical triage tool. That was developed by myself, Chris Peck, and Mel Dewar, who are the two healthcare homes establishment leads in Northland. There wasn't one when we arrived, and we thought we wanted to have a way of standardising a clinical approach to doing triage. It was an interesting little exercise because we knocked one up and gave it to Ken Leitch, and within 10 days he'd returned a prototype with a whole lot of plain English on it, which is always what you get from Ken. He's going, I can make this better than that. Then Mel got hold of it, and Mel's had a background in change management and refined it even further. But from the day we decided to do it to the day we launched it, and the practice was 3 weeks. The grand total price for 3 weeks of work was it's running, I think, was $3,000. So many other things in IT would have taken, scoping and RFPs and goodness knows what else. And it's quite nice to sometimes do something quite leanly and just get on with it. The only change to the form actually in the last 4 years since we started it was to put in a different coding system for same-day bookings being urgent or not urgent, to allow the practice managers to work out how many absolutely urgent slots there were. So the reason we use the tool too, if I open it up, is that in behind it, obviously you get the nuts and bolts of warnings and medication classifications. So you got to say you've seen them and put in some sort of history here. Whoops, sorry, can't spell. But the outcome data that our docs are putting in there allows us to make all those back behind the scenes decisions about supply and demand. It allows you to give an idea of how long things are taking and for each person that's doing triage, and allows you to do that some billing without having to go as far as opening up another screen. So you guys are probably using this anyway. Certainly if you've got new software, I don't know if Indices put this in or my practice are running it, but I would have thought your developers could do this relatively simply. I know even Ken said he could design an indice if they asked him to, but without it, you're actually asking your providers to do something that's probably not as clinically safe as it could be, and also from a business point of view, not as slick as it could be. So our system, obviously, if you say, no, I haven't resolved it, you'd say, who's going to take the next step? Well, they're going to be seen by a GP. It's going to be a face-to-face appointment, and it's going to be today urgent, today not urgent, or a future date. So that was the only change between the original form, is to have two to make sure that all your today really urgents were actually seen. So, and also some stuff there that if you decided that could be sorted, that they're going to ring and get worse, and you can bill us from there. We've got a zero charge bill on the triage form to show that the triage has actually gone through. And the reason is that it's not so much from a financial point of view, but it's because when you're looking at the template for same-day appointment for GP callbacks, it puts a $ up for behind the patient's name to show that the patient has actually been seen and finished with. So for the flow of work within the practice, that's how we work out who's being seen and who's been seen. So I was going to do that. You'll actually get a bill, and I can go okay, and then it'll finish. That writes back into medtech. So although I put hardly any content, you don't have to then write into the clinical notes. I've got up there just on the right. This is quite a way ahead. Obviously, 26th of July, so no patients appeared. But that is a daily template. That's my morning. So I start triaging on a Monday between 7:30 and 8:30. I do an hour. So does another doctor, and then a third doctor comes on for half an hour. So between 7:30 and 9 on a Monday morning, we probably have 3 or 4 hours of solid doctor triage time. This morning we triaged 36 people in the first hour and a half at Bush Road. So that's almost 2 full days work for doctors. We would have doctors triage at our practice around 45 to 50% mark in terms of resolving it. So we cleared a whole doctor's day today. The other 20 or so we had to see in from that first day had to be seen. But as you can see, there's book on the day appointment. So I'm just going to go into one of the other doctors, so Jeff Cunningham. He's doing triage from 8. He's got 3 book on the days in the morning and a whole swag in the afternoon. Monday afternoons get busy. One of our other doctors, Wendy, will have lots of book on the days. We have put these book on the days at that level, knowing what our days look like. It's taken a bit of fine tuning, but we've made sure that we've got enough doctors to see them. So you can see that's simply how our books look, and we do always want to match supply and demand in terms of not overdoing the number of people that we're seeing as extras. If on the odd occasion it is much more frequent to have a free book on the day than it would ever be to be double booked. And any bonus time of book on the day that's not booked allows the doctors to just catch up and get their breath. And for our associates, they get paid for that, whether there's a patient in there or not. We've got it fairly fine-tuned though, so most of the times, most of the book on days are used. GP triage itself, that's a normal template with 5-minute slots. They will run continuously all day. Our nurses, after that, about at the 9:30 time, our nurses start doing slots of triage right across the whole day. They often may only in a half-hour slot have 1 or 2 people to ring, but what they do in that time is catch up with some administrative load they may have. So they set aside enough time to usually field all the calls they need to, but also they probably got a little bit of spare time in that time. Mondays are pretty bedlam. I'm not going to let you look at it too long, but out of that too, you probably all have got ways of analysing data. Inside our practice, there's 2 ways of doing it. One of them is to use Ken Leach's simple KPI reporting tool, which I'll just set this back for 1st of March, so a quarter. So running his report there will give you some ideas inside bush rate around resolution rates. The resolution rate 30% is both doctors and nurses combined. You can see in a quarter we take a total of 2,262 triage calls in a quarter. So that's, if you think about it, it's 9,000 triage calls we're making. That's 9,000 appointments that would otherwise be made. If we're triaging away 30%, it's 3,000 consults that are actually sorted out in 3 minutes. We also, if you're looking at that, it's not big figures, where medical certificates and prescriptions are about 220. If you times that by how much you charge for them, you're generating some income during that time. We're fortunate in Northland to have a DHB that values healthcare homes and sees it as a way of improving care, both for the staff and for our patients. So we do get paid some money for running healthcare homes. This is one of the expenses that we probably do run, along with huddles. So it is recompense. The figures there too, so our doctors do 43% of all the triage calls, our nurses 57%. Mindful that the doctors do 43% in the first 2 hours of the day, and the nurses do the other lot in the next 6 hours. So it really is that we're trying to maximise the amount of prescribing time that we can, doctor's time. Otherwise, if we had a doctor doing it all day, we probably find that it wouldn't be quite as cost effective. Other figure that's actually of some concern, because we're in a big practice with multiple doctors not doing full-time work, is that we don't actually triage our own patients very often. So that figure there would show that only about 1 in 10 is triaged by their own host doctor. If you triage your own patients, you resolve their problem more at a higher rate. Also, patients often like being run by their own doctor. What we tend to do is look down the triage list when we're on triage and preferentially go to our own patients, even if it means jumping down a few people in the queue. But just because the size of the practice, the way we're doing it, it's difficult. Remember, if you're out of that 91%, 57% are answered by nurses who haven't got a registered doctor as their, so that makes a difference. On the right, very bottom there is an idea really of the total volumes. There's a better way of looking at which I'll show you shortly, because this has been extracted out of MedTech and has been now displayed in a much more powerful tool supplied by Maytag. So you can see really on, again, sort of Mondays are by far the busiest days, or Tuesdays after public holidays. And you've got to really be ready for that, because it's pretty disastrous on a Monday morning if you haven't got the staff ready to go, or the doctor's not there and you haven't thought that through, because it can be pretty daunting to arrive at 7:30 and that first hour have 30 or so people to call amongst 2 or 3 people without, if someone's absent, you're in trouble. So I'm going to come out of MedTech. Sorry, I keep dropping the screen out. And I want to show you Datacraft's tool, which is a much more elegant way of displaying the information I just showed you. So what they've done is they've extracted that same information I showed you from Ken, and they've put it into a much more broken down analytical form. You can see if I was just look at, if I was to select just Mondays, you'll get an idea of how busy Mondays are compared to other days of the week. So it should actually come up right. Select a Monday. Maybe it won't. That's good AGS to get done. Trying to do presentation in 1 week. I'm just rolling. There we go. So you can see on a Monday, it gives you an idea of core volumes by day of the week if you want to have a look at it. Monday's by far and away our busiest day, and they'll give you an idea really then also of how many have been resolved in triage, how many have been booked in, how many have been put into other days. I've taken that information and analysed a bit further. I've got a table I'll show you. But that allows almost a heat check for our practice managers to work out how many absolute guaranteed book on the day slots they're going to need to allow them to make sure we don't overload our doctors. The time spent triaging as well is interesting. We've got a way of looking at how our various providers, how much time they spend. Rob and Ann, who is on her way to becoming a nurse prescriber, does a lot of triage. She's a highly competent nurse who likes doing it. She's got a resolution rate of about 35%, which is really good considering she's not prescribing yet, and does a whole lot of time. I do quite a bit as well, just because I'm rostered on to do it. We have a couple of people that have decided they don't like the process at all and have almost opted out of it. We also are now looking at some of our providers who've got very low resolution rates because they don't like the idea of having to make autonomous decisions and generally pass everything they receive over to someone else. That's of no reflection of their clinical skills. There is no correct resolution rate. You resolve at whatever rate you feel clinically comfortable doing. However, from a business point of view, we have a round figure. We know most people, not only in Northland, but around the country, will resolve it. So we'll probably start having conversations with our staff about, look, you don't really seem to be enjoying this as much as you like, or maybe a resolution rate is not going as well as we'd like for whatever reason, and they can probably stop the process. That is not a real big deal considering most of the calls are with people that aren't registered to that person. So we've got some work to do in that regard. We think in Northland, looking at our data, because we know that virtually all the time in Northland, we have no capacity in our practices. None of our practices would have, lots of empty appointment slots all day. That we think that our resolution rate is probably about what you'd expect if you are under a bit of duress with space for patients. I do a certification role for the collaborative, and I get to look at around the country at the call handling statistics for practices right around New Zealand. And what I am seeing, and it's something that we probably need to be mindful of, is that the resolution rate seems to be very closely tied to someone's same day capacity. So there's some practices where 85% of all their calls are done by the host doctor, which means that they're talking to all their patients, are talking to their own doctor, with resolution rates of 15%. That, to my mind, is not an indicator of clinical decision making. That's an indicator of, I've got a spare appointment, I'm just going to see that person, I'm not going to try and sort it out over the phone. That might sound a little unfair, but I'm actually sure, looking around the country at what I'm doing, is that if you aren't under pressure to try and sort something out, or you're not actually looking at whether it's good for the patient, and you're thinking, well, I think I'll be turning away co-payment by not seeing them, you'll tend to book them in, which actually, as I said to you before, it's not that great for your business. It's not good for the patient, and probably even not good for you. So this data I'm showing you is really useful for being able to drill down into information that helps you make decisions. Go back here. Out of my practice, and this is actually from that data, what you can do with it. So this is a quarter between March and May. This is a number of book on the day slots we needed by day of the week. So on a Monday, there was quite a range there between 10 and 33, but the average number of book on the days was 23. So if you look down each day of the week, Monday's the busiest. Tuesdays sometimes almost got a slight overflow effect, and then the rest of the week's a bit quieter. But you can see there is a reasonable large range, and we tend to then cater for the top end of that range. So it might be, for instance, that we've got 33 slot on the book on the day slots on a Monday, and then 23 used, means that 10 won't be used. It would be, that's because it's quite a range, we almost always hit it directly, but some days we have got people who have got empty slots for book on the day, 1 or 2, and generally they're delighted. And that's the number of minutes we've spent on triage in that quarter per month. So it amounts to each call taken, as you see, around 3.5 minutes per call. The work days per month is just how many actual days we were open. So it only amounts to 2 hours of calls per day. In total, I could probably double that though in times by the time you've actually phoned the person, written your notes, and done whatever you need to do. But it's still not a whole lot of work per day, considering the practice of bush rate of 10,500 people. And as I said to you, we're doing, let's say, double that to 4 hours a day, but we've actually sorted out sometimes a day to a day and a half doctor's work. You're definitely well ahead in terms of business efficiency and not having to see people you don't need to see. We, as I said, are only amateurs at this. We're actually fine-tuning it as we go. We need to probably do some work about a triage tool I showed you about how you standardize the actual use of the tool. But by that I mean, are we all in the practice doing the same thing? Meaning that when you, what I do is when I manage to get through to someone, that's the time I click the tool on, and I generally click it off after I've finished dealing with the whole consultation. So my timer is from the moment I start the conversation to when I finish the work. It may be that other people's times are based on having a conversation, then opening the tool up, typing into it rapidly and closing it. Because you do see some people's average triage time, even with large volumes, is a minute 5, and some people are taking longer. But we think around average about 3.5 minutes per person. As I said before, I think we could start looking at triage champions to improve resolution, using staff that like doing it, using staff that seem to resolve well. And I'm sure that's better for patients as well, not having to come up. We are continuing to fine-tune our supply and demand in light of that data. Some of the stuff even I've learned in the last 4 or 5 days while trying to get this presentation together has made me think about what we're doing and thinking we got quite a lot we could still be doing to make this better. And that fast comment's really just around what I said to you about the collaborative itself, maybe needing to look about this principle of the patient test, that we are accrediting and certifying patients who want to be who I don't think are really using this triage process that in a way that's truly as good for patients as it could be. And I think that again, it comes down to sometimes an idea that not seeing people loses your money, and also not valuing people's time. So that's not for me to decide. I just know that when I've looked around the country, there is quite a range of resolution rates, quite a range of how people are doing this work, and quite a lot of different outcomes. And not there's a gold standard or perfect way of doing it, but it would appear that sometimes the principles behind why I do this aren't being as held as well as I think. So that's really all I wanted to say. I'm really quite keen though, because now I've finished yabbering on. I'm quite keen for answering questions or hearing comments, because I think we're all learning from each other in this process. And I'm certainly no expert. I'm an enthusiast and keen to hear what people have to say. So thanks. So Jess, you're learning some way of opening the floor so anyone can ask questions.
Oh yeah, I can definitely pick on people around asking questions, but I can kick us off. Can you talk to us or answer, I guess, talk to us a little bit around how you got over the line of getting some providers or GPs within your practice to triage when they were quite resistant? So we find that sometimes in general practice, we've got change makers, and we've got people that are really, really happy to give new things a go. And then sometimes we have people who are a little bit more resistant to it. How did you find that? Yeah, it came back a little bit, I think, even to what we might be doing in terms of fine tuning. Now, for most of my colleagues, the training of how to do triage was to show them how to open the tool up, literally, and saying, look, there's a way of doing this. This is how you do it. And most of them just went to it. I think there's still a reluctance, or it's quite different trying to resolve things rather than putting them on your book. And so some people have got lower resolution rates, partly because of clinical judgment, they're allowed that, but also partly because they can't be bothered. They honestly go, oh, look, I'm just going to book them in, I've got an appointment at 11 o'clock, just come down. So we do see quite a range of triage resolution outcomes, but most of them haven't been resistant. Some who were most resistant have actually taken to it most. They really like it. And some that thought they'd like it, I found it a little bit more trying. None of our nurses commented about it at all. Our nurses just get on and do it because they're good at triaging. And they resolve better rates probably than GPs if they were allowed to prescribe. They're also quite fast at it. So I think if you found someone, Jess, that was entirely resistant, you just say, don't bother, don't do it. Most people do like it, and it's actually something new they've learnt to do, and it's quite satisfying to do something that's slightly different, and also the feedback you get from patients and how pleased they are about having something solved without having to come in is enough often to motivate you to keep going. Myself, I think that you make a really good point there around how nurses still remain triaging. I think sometimes there's a misunderstanding that once GPs start triaging, that nurses will stop triaging, which is a bit of a myth. I think most practices will still withhold and have a whole lot of nurse triage in there as well. Do you have a bit of can you talk to us about what your split within your practices is, how much triage your nurses are doing to your GPs?
Yeah, that's I think it's 43% in the last quarter. 40% were done by GPs and 57% by nurses, percentage of the triage calls. But in saying that 43% is done in 2 hours between 7:30 and 9:30. From 9:30 to 5, the rest of the day, the nurses field the calls. So we do the bulk of the real volume of calls comes in that first couple of hours. I think we have thought about doing a second triage slot by doctors just before lunch and late afternoon, and we may still do that. Our nurses, remember when they click off, they sometimes click off that that it hasn't been resolved in triage, but in fact, they're coming to us with a request for a prescription. So they haven't resolved it, but they'll go back and actually finish the process. We just, I don't think, have a capacity to put a doctor on all day. I think they'd be sitting on their hands for much of the day.
Yeah. Just to follow on with that, Helen's got a question around nurse resolution rates similar to GP resolution rates.
Yeah, so some of our nurses resolve at a higher rate than our doctors, and they're resolving at a higher rate even without running prescriptions. So you don't make, this is tricky. So, why is that? Are they making the right decision? You don't know. Or are the doctors making a decision that's not about bettering patients' time? It's hard to know. I think that it's something we need to probably display in private with the nurses to show where they lie. We were looking at it today, and some of our nurses resolve at 35% and some at 6%. And those ones at 6% are some of our most competent nurses. So there's two things there. One of them, they may be not using the form properly even. They don't understand what it means. That's one thing, because we haven't gone back to revisit that. Or they just don't like making a call. So that's a little hard to know. But nurse practitioners are incredibly good at resolving. They've been doing years of triage anyway. They can now prescribe and diagnose and do investigations. Data we've got for them is they're quicker and quick at doing it and good at doing it in terms of resolving. Someone also had asked, Nikki had asked, someone said, no, Sue said, do your receptionists put people on the triage list for you to call, and does everyone seek an appointment that day go on your triage list? And the answer to that is yes. So every incoming call asking for a same day appointment gets put onto the triage list. And we call back everybody. We've had to call back actually just virtually everybody because of COVID too. So, and almost everybody seeking an appointment, we have to ask them about respiratory symptoms, one, but also even children in the past who were could be booked on the day without bypassing triage, because quite often kids were needed to be seen, have now been put onto triage. So we're triaging every single person. I think we won't go back to allowing the coordinators to put children on. We found that our resolution rate for children is really high as well. We thought in the past that they all had to be seen. And in fact, we realised that no, most of them don't need to be seen. They can be sorted out with advice. So, everyone gets put on, and they are ringing up Sue at the moment just saying, can someone give me a triage call? They actually know what the rules of engagement are. Someone said, Bro said, on same day thing, how do you record each failed attempt on your contact template? That's a good, so what we do there is we put just NR, no reply, and the time we ran. So it might be NR 812 and leave the phone number there. What we do on our template is the moment we successfully go through to somebody, we put the timer on. We say they've arrived without printing a slip. That inside Medtech puts a timer on. It means that the next person coming onto the system can see who's on a call, because it's actually got a timer running. It goes 0, 1 minute, 2 minutes, 3 minutes. If you don't get through, you can always just turn the timer on. You reset the appointment, goes to 0, and put the no reply. Our completely no reply rate, the rate of actually not getting through to anybody because for somehow it's dropped off, is something like 4%. So we don't have many people that we don't actually get through to. Occasionally we have this terrible thing where someone rings back the next day and said, someone was meant to ring me back at 3 o'clock yesterday and never did. It happens, but not often. But yeah, so we make sure that we're not stepping on each other's toes by using the timer function, and also that $off sign, which shows that the person's been finished. So it's $off saying, even if it's a zero charge, everyone in the practice knows that person's been completed. So what other thing? Moira said, why do you huddle after triage? We huddle before triage. We start triage at 7:30 in the morning, Moira, and like for instance, on a Monday morning, I was saying this by 8:30, which is our triage time. We do that at triage at 8:30 because that's usually when the majority of the practice team have arrived. but we've done already an hour of solid triaging, and most days that first hour is probably the busiest time. We don't open the doors till 8, and we've usually started fielding calls, a whole lot of calls. I think it extends our hours actually by doing that. I mean, we're consulting at 7:30, although we're not seeing patients at 8. So we huddle only, practically speaking, more at 8:30 because that's when most of the people have arrived. It also gives those poor people who've been thrashed at triage a breather, maybe. What else we got here? So is the triage tool, so Margaret says, is triage tool available, or would one need to set up their own triage tool? The triage tool that I showed you, if you're a MedTech user, can be installed by Ken Leach, and it's actually paid for in Northern New Mayte. He charges some figure like $150 a year license fee per organisation. So it's a matter of getting hold of Ken Leach. If you're a Mayte practice, then we can have it installed and we can get it set up and put onto your patient dashboard. If people are using Industry, I think that Ken's quite willing to work with Industry to create the tool if needs be. I'm not quite sure how you do that work I showed you without the tool. It makes such a difference for the leanness of the process. What else have we got here? Let's have a look. Yeah, so Helen here talking about using GP to support times and GP full times equivalent have diminished. Definitely it's helped in our practice. We're two full-time equivalents down, and we're coping. There's no possible way we would have coped before Healthcare Homes. We were already fully booked with extras. It was literally a train wreck. We've got less full-time equivalents, and we are handling it by doing triage. The other thing we're doing is that I mentioned is we've got a really high percentage of our patients on a portal, and that means we're starting to do a lot of asynchronous work with our patients without them having to ring up or make appointments. And it's a little hard to quantify, but we did, I think last year, incoming, outgoing, somewhere like 25,000 incoming, outgoing managed health messages in a year. So you then add that to 9,000 triage calls. We are doing as much patient contact with portals and triage calling as we used to do entirely face-to-face or in-person consults. So we've doubled our patient interactions by triage and portal use, which I'm sure has made an enormous difference to our workload. It looks different to doctors. It is actually seems to be extra work. It does feel like you're doing different work, but I think what you're not seeing is that what it used to be like or what it would be like if you weren't doing that. I think it would be absolutely horrendous from a point of view of your care team wellbeing if we weren't doing all that work. I think it would be really, really tough. And we are trying to set aside time. We do certainly set aside time for triage calls, but we're also trying to set aside time for the virtual work. So people that are doing portal work, which does take time, should have set aside time in their day. I'm not a great fan of us thinking of adding more work into the day. And we've just had a revisit of portals in terms of rules of engagement with our patients to say you can't order up and expect things to be done on that day. We've got up to 3-day turnaround. Don't use it for urgent stuff. Don't ask your GPs to order your medications for you. It's a re-education process. I think we're all learning. But yeah, you're right, Helen. If we hadn't got triage time to do what would have otherwise been in-person consults, we would have been wrecked by now. Good question too, that someone's asked about how many patients need to be seen after hours or acutely or adverse effects after triage. That is something that we would really like to look at. You know, how many have actually run back and had to come back another day or had ended up in ED? My guess is that it's not all that many, because I think we're actually very defensive as both doctors and nurses about making clinical decisions over the telephone without being able to justify it. I mean, you've got to be defensible in your care. And quite often I think we err on the side of caution. We seem to go on like certain things you just can't sort out in 3 minutes over a phone call. Some of our practices quite wisely and cleverly decided that at that 3-minute mark, if it seems that they can't resolve it, they've actually worked out a way in their triage process to change it into a full consultation. They just tell the patient they're going to just take the whole 15 minutes if they're, and I can't do it justice in 3 and would like to turn it into a consult if the patient's willing to pay for a telephone consult at the time. We are very clear that our own triage process is triage. It's not to drift into a consult. That's really awkward ground. So even during COVID, we carried on doing triage and putting people later in the morning to ring back properly, either by video or by telephone consult, and we never let it drift from being a purely triaging process through to a consulting process. They're 2 different workflows altogether. But I think that the question around whether we've actually caused adverse events or ended up having people seen acutely elsewhere is really, really good. I think that's something we haven't done and probably should be done. That's the reason we have these meetings, because some of the people come up with really good ideas because they're much smarter than we are. So how many patients, someone said, how many patients do you have contact with per day, both telephone and triage and face-to-face? So both telephone and video consults are actually backed right off since COVID sort of hasn't been quite so prevalent up north. We, on an average day, if you look back through that data, we're, if I went back to my slide, triaging somewhere between Monday 60 a day to most of the quiet day 30 a day on contacts with telephone triage. Then again, so you're adding in then our days of obviously face-to-face, and so face-to-face at Bush Road is something like, in-person consult, something like just around 30,000 a year, and our triage call is about 9. So we're still seeing many more people face-to-face. And I said we've also got our portal work. So still predominantly we are seeing people in person, and in fact people like to come in and we like them to come in. And I think that much of our success with this is because we know our patients well, and we've had the years of in-person consults to let them know who we are, and they feel confident about talking to someone who they know on the phone. We generally hardly ever would talk to someone we haven't met. We've been at it a long time. I've been at my practice 25 years. Most of the doctors at least 20. We're a pretty old bunch of people, and we've probably seen every single practice person in the practice over that time, which makes it a lot easier. And someone said, Moira's actually asking if we ever charge for portal work if it's very involved. That we've just had a big discussion about that, Moira, and yes. So if someone is wanting an explanation for something that looks like it's almost a consultation detail, yes, we will actually tell them. Our rules of engagement say that portal is for messaging. It's not anything that requires consultation. If via the portal, will be charged at rates, and so we do bill people for that. I'm not a great fan of doing that. I think that what I find trying to do anything more than a message that goes to and fro quite rapidly, it's a ping pong thing. It's much more time consuming than actually saying, look, why don't you, let's organise a consultation. Do you want to do that via the phone or come in? Because you quite often find that backwards and forwards, you might write what you think is a really nice detailed thing, might take you quite a while, and then bang, they write back and go, but what about? I think that I've changed on our Manage My Health. It doesn't give you a chance to eat. It doesn't say consult your GP or consult your nurse. It says message. And I say to people, this is like text message length. It's just, it's not to be used for anything more than a couple of lines. And most people stick to that. If they don't, then it's a matter of re-educating them. Say, I can't sort that over, can't sort that out, and need to make an appointment, or this can't be used for acute problems. People sometimes do try and use it, and it becomes less as people become more aware of what it's for. There's always going to be outliers and people that don't know themselves, but they're few and far between. Someone said, are there stats for how many times do they get it wrong? I'm not quite sure if that's about how who's getting what wrong. If that's to do with clinicians getting it wrong, it would be pretty hard to suss that out, because I'm sure that there'll be some people getting it wrong in any form of consults. As general practice, I get things wrong all day, every day. That's just the nature of the job. So whether it's, I'm not sure if that means getting it wrong over the portal, telephone triage. it's probably not any more likely than getting it wrong if they're sitting in your room, if you use it appropriately, if you're making sure that you're carrying out a safe process. We've got a fair bit of peer review goes on inside our practice, because the fact is we see each other's notes, we see each other's triage, content, quality, clinical decision making, and we do have doctors' meetings, and there wouldn't be very often that I'd bump into reading someone's notes where I thought they were doing something that wasn't clinically sound or safe. We are defensive as GPs. We try not to drop the ball too much. We are sort of, I guess, slightly defensive. Hence the reason they're quite hard to get us to do new things, because any new thing actually potentially could not go well, and people don't like the fact that that's part of their professional ethos is not allowing things to go wrong. Something else, Jess, what else you want me to mention?
Oh, that was just me putting a plug in for our 4-question survey. So if you could provide us with some feedback, it is 4 multi-choice questions, so you're not expected to write a novel at 7:30 p.m. But it just helps us develop and grow our education sessions and do better and continue to do better. So part of our quality improvement for tonight. I think that we've been going for an hour, Andrew, and it's probably time to wrap up our Monday evening.
I reckon it's the shortest day, so and I said I wouldn't take an hour. I did. I apologise to all of you. I can't stop blathering.
Yes, and we've got a recording, so we will send it out to the Healthcare Home Collaborative to share onto the Healthcare Home leads. So if you just contact your Healthcare Home lead in your region, they will have a copy of the recording in the next 24 hours. And we do appreciate, Andrew showed us a slide on there that does have some patient data on that, and we really appreciate you not zooming in on that patient data and respecting the privacy of those patients on there. So thank you for that. We will get that recording out to you, and we really appreciate you all coming online. And it's so nice to have a national bunch of people, but it's also really lovely to have some of our Northland folk on here as well. And we hope that this has been really useful for you. I've also, in the chat function, if you missed it, I've put Ken Leach's email address. If you are wanting to get hold of the form, he is really approachable. He will be able to walk you through exactly how you can do that within your practice. So yeah, that's all from me. Do you have any closing comments, Andrew?
No, thanks. And anyone that want to get hold of me, especially around North, and you want me to come to your practice or talk to your staff about any of this, I'm absolutely happy to do that. No issues at all. And anyone wants to contact me out from outside of North, and go for it. I'm happy to talk to you. So thanks.
All right, we'll finish up there for the night. Thank you all, team. It's been a pleasure.
See you then.